continue that conversation. So up next, the beautiful people over at Insource, one of our sponsors for today, have funded a good friend of ours, Lee Rickles, to get involved in today's conference and provide us with a presentation. Just to give us a quick introduction, Lee is the Programme Director and Chief Information Officer at Yorkshire and Humber. How the devil are we, Lee?
I'm doing okay, Sean. It's nice to see you again.
Indeed, yeah. It's always a pleasure.
Yeah. It's good to see you, and it's good to follow Ming. So it's good to have a good warm-up act.
Indeed, yeah. You can't get much better, really, Lee. So happy with that.
It's good to see Ming as well. So yeah.
Perfect. Well, I'm just going to wait for the slides to get loaded in, Lee, to make sure we're all ready to go. And then as soon as that happens, I will leave you to it and we'll do a bit of Q&A afterwards. So Clyde should be with us any second.
Okay.
There we go. Perfect. There we go, Lee. I'll see you in 20 minutes, sir. And yeah, thank you.
Yeah, super duper. So yeah, good morning, everybody. Ming set a really good context from the national perspective. I'm going to be focusing very much at a trust and an ICS level, and very much of a focus around data. And I think there's some really good points that have already been made around standards, trust of that data, and also the really important bit that was made as well about how do you transform services? How do you use data to get information and intelligence to work together? How does that allow us to lever resources? And I'm going to come up with a couple of examples where we've, from a Humber Teaching NHS Foundation Trust point of view. So as Sean explained, I'm the CIO Humber Teaching NHS Foundation Trust and the Director for the Yorkshire Humber Care Record. We host the Yorkshire Humber Care Record. It's something we've been heavily involved with for a number of years, and it goes back to the good old Lycra days. But the key bit for any of these systems is the core data. How do you get it? How do you make it work? And then what do you do with it? It's great having data, but what do you do? So just give a little bit of a background so you can see the organisational context. You can get a feel for size of the organisation and what we are. We are a community mental health and primary care provider. I think we've got 8 primary care GP practices at the moment. They're merging and changing all the time, so it could be subtly different from earlier on in the year if anybody does some double checking. We run from a lot of sites across North Yorkshire, East Riding, Hull, and we've got services up at Whitby, down in Gull, across Withensea. We do cover quite a big rural area, but we do have some urban areas of York and Hull, and also areas like Beverley. So a bit of a variety there, and we predominantly cover adults, older adults, children's mental health services, children's services, so what historically would have been school nurses, health visitors, physical community services, run a few community hospitals, Whitby being one, just recently had a big revamp, which is brilliant, and the Malton Community Hospital as well. Just a bit of information there on the activity numbers, which is quite fortunate with the recent digital maturity assessment. We've pulled a lot of these numbers out for that submission, and just how much we spend. The number there, we do provide some specialist commissioning services around children's mental health. So although we are a provider, we do actually commission services as well. So and it just gives you a view of how much we actually spend. Now, a couple of the more important bits that relate to today's presentation are we mainly use 2 EPRs. System 1, this is all legacy from the good old national programme days, and we're now emerging from in a different sort of direction. But we've got System 1, which is really physical health, community hospitals, addiction services, them type services, and we was first to type for mental health on Lorenzo all the way back in 2012, and we do that with our mental health, older people's, children's CAMs, or all them type of services. There is a level of overlap, and I'll touch on some of the bits later on of how we've had to deal with that particular issue of having 2 very different systems, in other words, how you get to the data, how you get the information, how you get a single source of the 2. And we use the Insource data management platform, which we have done for a number of years. We had that in place before Lorenzo was implemented a while ago, and also how that's evolved as well. Just a bit of the background. Really brief bit on the infrastructure, just so you can get a feel for the organisation. On Lorenzo, we do get extracts several times a day. We can be fairly regular with extracts, albeit it can be a bit draining on resources. It's predominantly the same EPI that the acutes would use, and there are some challenges around that because it's very acute orientated. There is a mental health act capability, but we always have that challenge of trying to make that square peg fit in a circular hole with that particular system. System one, we have the daily extract solution. I know they're going to some real API stuff, and the data structures are very different. With Lorenzo, you've got a very clear schema. You can get access to most of the information, if not all of it, and it does feel quite well. With system one, we have the enterprise extract solution, which basically it's feeded by per unit. We have 15 units, and it's certainly different. You also have the challenge around a lot of the historic data is read code mapped to SNOMED rather than just pure SNOMED, which can be a little bit interesting. Them to say, not including a couple of other systems like PC-MIS for IAP services, and we have our corporate data as well, so like estates, HR, Datex for risk, etc., etc. We do use the Insource data management platform, and for us that's been absolutely essential because we provide so many services and we've got the different systems. The key bit we've got with that platform is being able to basically pull, do the ETL routines to pull the data out from both of them big systems, as well as the other non-clinical systems, but very predominantly around clinical, and then pull that in to go through that deduplication, merger, normalization process to create that single record of data relating to that patient and that professional and that location. But again, it's we're not working in a world of several SQL databases in the back end. It creates that single view, which is absolutely essential if we're looking at how we do our capacity demand, how do we do our performance and information management, how do we do it if we know what's our PLIX, what's our and our service level costing, even to the point of how are we going to make sure that we've got our discharge dates appropriately set. Another one is a lot of the medications information. If we're optimizing our medications, how do we know that the drugs are tying back to the patient, getting better outcomes? So a few examples there, but the key bit is having that really good data. Now, we have been digital for quite a few years on both of them. We do have copies of paper, unfortunately, that are sort of semi-structured, but the majority of information does go in a structured way. And the issue there is getting it all in a format that actually adds any value. Otherwise, we are just feeding the beast. We use Apache and iFi. We just started really using that, and that's been quite neat, to be fair, as well, when we complement that with the other solutions, just because of that, shall we say, more lower code routing, applying logic. And I will touch on that on one of the case studies and how that's benefited when we've got the data together. We use Power BI. Lots of people do it for a lot of our dashboarding. And also we do have an Azure-based integration and portal capability. And that capability links directly to the Insource data management system and the EPR solutions. It varies a little bit depending on whether it's real-time or not, depending on the REST API, depending on whether we've got asynchronous, synchronous, or running subscription services against them via proxies. And really that ties into the Yorkshire Humber Care Record solution as well, which we host. So a little bit of background there. I better get moving because I've done a lot on background. So what does that mean? What does that add value to my trust and my ICS Humber in North Yorkshire? How does that work? How do we, the different systems, how do we bolt them together? So the key bit I would always say on data is if you haven't got a single source of the truth, if you haven't got a very clear schema, hierarchy, you know what your definitions are, you've got it coded, you've not got that duplication, you're comparing apples with apples, you're always going to struggle to make decisions whether using that for real-time data for frontline services or secondary use for capacity demand, or even how much services are cost and are they effective. And then when we link that with other organisations as well, we've got to work with standards and a good data quality, because if we're not using a good data quality, how can we link data together with our partners that need to work together? And the two examples I've got here as what I would class as good practice case studies are where we are working in a system, we are working with partners, and there's two there. I'll touch on the Federated Data Platform at the moment, where we've got the Palantir Optica Virtual Ward and Optica Frontrunner. So Frontrunner is basically how do we manage discharge more effectively to get people from acute into community, work within all our peers, having the information all in one place so we can start that discharge planning and then manage patients in that community with the appropriate resource against all partners with a single clear view of the record, which is very similar to the virtual ward solution, which is also a very similar position where different organisations are doing different level of care, but in a virtual way. And in a number of cases, we could have very different providers or different providers in them patches, including CICs, actually providing that care. And our systems aren't as joined together from a data perspective, but we do need to provide that coordinated care. In the good old days, you'd probably have a really, really big room with a lot of people in and spend a lot of time running through a lot of paper rather than using automation and data to minimise some of that work. So we have been on the Federated Data Platform piece for a while in Humber and North Yorkshire, albeit we're not as necessarily as advanced as some of the other areas that Ming suggested. But what we've done with the Palantir solution, at least while we've had the benefit of what we've got with the data layer and the tooling we've got, we've been able to not actually implement the Palantir Linux box that you've got to stick into your infrastructure and then has a massive overhead to management, repoint, redirect. And again, we are talking in some cases with clear data, in some cases the ID data. And there's different custodianships and levels of safe haven around that data we've got to apply. So what we've actually done is we've gone a slightly different route, which is actually where we're messaging Palantir, and we're messaging it using from the Insource solution, and also then using the NiFi protocols to basically, as the warehouse updates and it fires off the subscriptions and the changes, that information then gets messaged to Palantir using standard SSL certificates and encrypted encryption. So so rather than having something on our infrastructure now, as the Palantir solution is currently, it's an interim, but the Federated Data Platform is out for its longer term solution. From our point of view, that creates a very eloquent solution. So I'm not having to pull out a Linux box if things change and we end up with a different provider. We can just repoint the messaging and then working that messaging. The only negative bit is I really want to work in a file language, and we're not quite there with Palantir. We've got a set of data definitions and it is coded, but it's not working in Fire release 4 and having the appropriate resources, which from our point of view would just move it that way forward. That's something we're working on, and it should and when we got that'll be even more effective on them items. And this is only really around direct care, and we also have the ISAs, DPIAs and MOUs in place. So we are the custodians of patients' data. We need to really make sure we manage it appropriately and we don't misuse that data. It's absolutely essential. Now that's the one example. The second example is the Yorkshire Humber care record. Now what we have there is a shared care record that covers the Yorkshire Humber region, so around 6 million patients, of which we are one of the partners. And in there we've got a shared care record and a population health management solution. The population health management solution, it's all in Google Cloud. It's separated off as a separate entity, so Google don't get access to any of that. We are working with Deloitte on that piece, and also a number of companies, SME, Synenetics and Logic on the shared care record piece. Now, from the data layer we've got, and because we have that single source of the truth from the Insource data management platform, it's really straightforward to then take the fire appliance that we've built on the Yorkshire Humber Care record to then map that to the data fields. We've got an appropriate schema, and then that can also be used by other providers, because you also have other providers in the region that use the similar data source to then well, basically messaging fire. So basically we can then share that in fire as a federated solution rather than a persistent solution for direct care. Now that might seem quite straightforward, but it's quite complex. Data quality has to be absolutely right. You've got a lot of definitions there against fire, and also against how you would do the SNOMED and or pick up other coding. So like DMDM is another really good example for the medication side, especially when you're looking at complex medication needs with pharmacy, and because you know the pharmacy team get information from lots of different areas and need to make particular decisions, for instance. In that respect, and the population health basically is a way of from my organisation's point of view, it can pull the information based on how an analyst can cohort that data together based on the population health solution, but it does get de-identified and it goes through an appropriate process that ensures we've got our compliance against 251 for secondary use. I think the key bit on both of them is provision, having a good set of data in the background, with which, you know, I think the Insource data management platform really does deliver it for us, and then use the other tooling that we've got to really provide something that we can then work in conjunction with our partners, whether that's ICS on things like FrontRunner, or on the Optica virtual ward solution, or on the Yorkshire Humber Care record, where we're really looking at, you know, ambulances having access to crisis plans when the 999 comes through. Has there a crisis plan, mental health crisis plan? If there is, yes. Do we need to do something else? Yes, no. If we do need to do something else, is that we go to the crisis team for our particular trust, so we can enact, and then they can send information to us. Or is it actually to put a psychiatric nurse in the back of the ambulance to manage that crisis plan? So a couple of examples there of what we have got done, but I would say the key bit is having good data. If we didn't have the good data and we didn't have the good data tooling, forget the rest of it. It would just be an absolute nightmare. You just couldn't pull the data together. And we have found that with my other hat on as Yorkshire Humber Care record program director. If you don't have the right data, it's really hard to put some things in. Now I'm aware I'm probably getting to the end of the presentation, and I think I'm still okay for time. So what does that mean from a Humber point of view for the future? We are pushing more open source technologies, and we do find with the way we work with Insource as an open platform capability, it works quite well. But there is some opportunity around open source technologies. That's not for cost saving, by the way. That's just because it's a slightly different model of operating. The total cost of ownership against open source against vendor is very, very, very similar. And we do see a blend. But yeah, I mean, the NiFi is a good example from Apache, where we can utilize technologies to really make things a lot simpler. We want our data management platform is the last solution to move to the cloud in our infrastructure. It's mainly being paced by what we've been doing in the trust, and we're currently out for our next generation EPR. We're currently at the end stage of that procurement, so and both our EPRs are currently clouded as well. So there's a piece where it shouldn't impact the operational performance. It's more the cutover and doing validation processes. One we really are keen on is the faster data feeds. And I think based on the infrastructure we've got in place, it would actually be really straightforward to achieve, just because there's nothing worse than all the sit reps we have to do for so many different masters, rather than if we can do faster data feeds and have that in a federated data platform, which I've already shown we can do that now. It just makes life so much easier. You get tech data once, use many. And really want to get that fire message in from the Yorkshire Humber Care record directly into federated data platform, but do it on the legal basis. So if it is for secondary use, it has to be de-identified. If it's for direct care, that's fine, but let's make sure the ISAs reflect the use cases and make sure it's appropriate, because you know that fire messaging means even though we put it into federated data platform, it could be in other solutions as well. And I think calling the federated data platform one thing is probably a misnomer. Realistically, it could be operated at different organisational ICS and national levels. I've touched on the EPR. I'm expecting to have a bit of a rework on the data warehouse because our next generation EPR will have a slightly different underlying structure if the vendors come back on what our requirements are, which is very much that separation of open and application layer. It would be quite interesting to see if we have any open air derivatives in there, another one to map to. But again, that open air can give quite a good set of data and analytical capabilities. And also move to that lakehouse, data lake, data house model, which I am talking with Insource of how we can apply that, especially around the AI. And the reason why AI is, although we do have a lot of structured data, our services do seem to write a lot down. And I really want to exploit that natural language processing within documents. That means things that don't necessarily get coded, we can start learning how that coding can apply, get it in the system and get better data and better outcomes from just natural language, rather than having to make clinicians tick even more boxes or put more information into systems that isn't a natural flow to improve their experience. And also the final one is the ICS data layer, which we're currently working with our colleagues. We're getting there at the moment. A lot of the work we are doing is around the optical quality a bit, but there is still that final decision to be made on the direction we go for. So I think that takes me through the presentation and really to questions. So Sean, do you want to come back in, sir?
Indeed, I am right here, ready to go. Thank you, Lee. Just the standard question of are the slides going to be able to be shared afterwards?
Yeah, I've sent them out. So if you want to make them available, that's great. I'm just going to have to stop sharing because I think I'm sharing the thing. I can't actually see the. I can't see the.
Not being able. Just going to say, not being able to see me is not a big problem, Lee. So yeah, whatever's comfortable for you, mate.
Yeah.
Just as a note to delegates as well, the poll is on the screen right now, the first one of the day. Please do get involved in the poll on the screen right now. As mentioned, this presentation was brought to you by Insource, who of course is working with Lee and the team directly. So please do get involved to ask any more questions. Lee, can we answer a few questions now? Is that okay?
Yeah, go for it now. Go for it. Yeah.
You're an absolute star. So Shalini came through with the first question, which is blockchain tech used in the EPR at the moment, Lee?
So no, it isn't. It's something we've been, to be honest, the blockchain is something we've definitely looked at on the shared care record piece, especially using blockchain to create that the credentials and the authentication around the technology. But no, we don't have the blockchain. We don't have blockchain in action in the trust at the moment.
No problem at all. So two quite similar questions here, but I'll ask the first one here. So Ming mentioned the inequalities dashboard for ICSs. Are you currently using this at the moment, and if so, what kind of impact is that having?
So we are using it, and I think the thing with the inequalities dashboard is when you tie the inequalities down to potential, shall we say, waiting lists, and this is a really good example, you may be risk evaluated. So you could have somebody from a, and I'm please don't quote me on these examples, but they probably are right. I could well be in an affluent white, heavily white group of economic group, and I might have the same risk as, shall we say, a racial minority that's in a deprived area. It's not always that way, but or even I've got learning disabilities, etc. You could all be evaluated exactly the same way, but what that dashboard is helping to identify is these people are still taking longer to receive treatment, even though they're being evaluated the same way. They're on the same pathway with the same level of risk. So the issue there is how we engage with different. So this is taking the data and then act upon it. Of how are we working with the different them different groups to make sure that they don't lose out. That why does it take 4 weeks longer to get through a waiting list for somebody with learning disabilities to somebody without learning disabilities, but you've all been assessed exactly the same. So that's where that type of information comes, can be quite good from a grouping into smaller headcount. Overall, it's also quite useful when you look at the social care aspect and local authorities who are generally a lot more savvy on these type of things. And then where you're looking at overall services, because you might need a wider service wrapper which becomes clearer when all the partners really understand that. So yes, and it is quite powerful, but you've got to do you've got to have the resources and staff to actually make that effective, and that's one of the challenges at the moment. It's quite a lot of challenges around resourcing and how we've got a currently restructuring service, especially around the headcount reduction we're having in our ICSs and NHSE.
Yeah, an uphill walk, should we say, Lee, at the moment. So last question here before we move on, great one, so we'll sneak it in. Is the PHM work helping improve outcomes on the ground in the trust? Any particular successful programs you can mention, Lee?
So one is around, I mean, I didn't touch on it, but carers. So we did a whole thing around the data and linking into carers, which doesn't, although we record it, we don't necessarily act upon it. And then looking at carers and then the outcome against carers, because we've got primary care information and we've got other services, we can then start to see that, you know, I mean, there is a known link that carers do need that extra care, but because we've got the information and it's joined together, it allowed us to then work with them carers and the patients to then come up with additional carer online care and develop carer support packages, and whether that's a call center approach or you actually effectively you can create your own online app. So that's one example. The other one is around medication. Massive improvements around medication outcome, how it impacts patients, you know, and again, you know, the medication can have such an impact on somebody's how they feel, how they operate, in a positive and negative way. So and the other bit on the medication is being able to optimize the cost of it, especially because you know, a high cost of most services includes, especially with mental health, is a lot of medication, unfortunately. And then trying to redirect where we've got my medication, can we do the talking therapy? So there's an investment case there. So a couple of examples there that hopefully help answer the question.
Absolutely perfectly. A pleasure as always. Just a huge thank you to yourself and of course the Insource team for getting involved in today's conference. Had just a quick note here from delegates, and I'm sure there's probably a few others in a similar line, mentioning that it'd be great to further the conversation, get a bit of an idea of your team structure and size and how they can learn from some of the work you've done there. So thank you for that, Jane. We'll link you up with Lee afterwards, and any other delegates as well, please do fire an email across and we'll get you linked in. Lee, cheers again.
Yep, thank you very much, Sean. See you later.
See you soon.